What's the clinical presentation?
Multiple, a few different people, different names, and they come and go at will. I mean, not at will, they just come and go spontaneously.
Yeah. Right. Everybody would agree that that's kind of key features?
Yeah.
Usually you have a lot of memory gaps.
Significant amnesia,
Because when you
absolutely.
turn into another person, you cannot remember you are the other person. Usually it's wrong observers.
Anybody want to argue the other side? What we have been trained and to some degree exposed to are the people who present like that. They are less than 10% of the clients with dissociative identity disorder at the point of diagnosis. Mostly this is a disorder of hiddenness. You will not know it when you see it. It's intrapsychic, it's not behaviorally enacted for most people. When you see somebody who, where they come out and they regress into a child person, the first time you meet them, you want to work very carefully to understand what's happening in front of you. Because mostly that's not the presentation until the person's in crisis. When the person's in crisis, that's when you see that. It takes about 7 years of multiple misdiagnoses to get a diagnosis of dissociative identity disorder. So mostly this isn't seen. It's an intrapsychic definition almost. So the sense of subjectively different selves is an internal experience, not one that people behaviorally enact for the most part. When they do, there's always the question of why. And you have to answer that question. Very often it involves some combination of access to features. When somebody is that overt first time you meet them or soon after you meet them, in the absence of a crisis. If there's a crisis, that's when you would expect it. It's usually not diagnosed until after age 40, although its etiology is almost universally in childhood. There's very limited evidence that after about early adolescence, you can develop this at all. That if the trauma, let me say, I'm sorry, if the trauma that typically is associated with this, about 99% of cases, didn't happen before age 12, chances are you're not going to get here. This is early childhood trauma. There may be some cases that are, but there's not been a documented case where it's been past adolescence. So it's essentially a child and adolescent developmental trauma disorder. What's really scary is that this used to be considered, the Kaplan and Sadek textbook of psychiatry, the classic, identified this as rare as early as the mid-'80s, just like it identified child abuse and incest as rare. Only recently, people really even started to bother to study, to sample, using more structured measures. And they found like a 4 to 6, most of the studies inpatient give you about a 4 to 6% prevalence rate. And the majority of those are undiagnosed. That's the first time anybody ever said, hey, you've got a dissociative disorder. So this is something we don't see. If you don't ask about it, you're not going to get typically people volunteering these kinds of symptoms. All right. And so what that's led a lot of people to think is there's a window of diagnosability. What do folks with DID get diagnosed with before they get that diagnosis? Everything else. Really. Panic, depression, personality disorder, bipolar disorder, depending on the presentation. You name it, and they are diagnosed with it. And look like it, too. What's the most common presentation clinically? We get a lot of those. Someone typically middle-aged, typically female. Typically female. Although there's a whole literature of males with dissociative disorders, but typically female. Who is chronically depressed and dysphoric, who's maybe had some anxiety, who has difficulty in interpersonal relationships, who's essentially unhappy, and wants some help.
We see a lot
like
of those.
Everybody you see?
See a lot of those.
Yeah. Right? So the problem is that DID doesn't have we don't have a good finder image. if you know what I mean. The diagnostic criteria are of very little help in the DSM. Right? It's real simple. That person has to have one or more subjective sense of a different identity that routinely takes full control of the person's behavior, essentially. People don't tell you that. Ask them that question. Do you feel like you have more than one sense of subjective identity that... So you got to really look for this, unfortunately. So why don't we stop there, pause there for a minute. I know I've given you a lot of information, but what should we really be talking about with these disorders? What's important for you to talk about with us? You tell me. You're here, it's after 8, you've had a long day. What do you want to do? Questions, comments, reactions?
What can you do? How can you help them in as little as time as possible?
Question. How can you help them in as little time as possible? Don't diagnose them. Once you do that, you're going to grow old together. You're a psychotherapist, you're going to grow old together. Unfortunately, these are long-term treatments. There is very little evidence that you can resolve this quickly. But the good news is, even if you have 10 sessions, there's some stuff you can do. Let's get into it. Typically, the psychotherapy follows a phasic model that goes back to Pierre Janet in France in the late 1800s. More recently, kind of reformulated by Judith Herman, and then you're going to see Chris Courtois' name in a minute, looking at developing a standard of care for the psychotherapy of trauma. Stage 1, safety. Stage 2, remembering mourning, which is exposure, work, breathing. Stage 3, reconnection, or learning to live life without being so trauma-driven. Let's go through what that means. Chris Courtois published a nice text that identified a model that's going to become, in September this year, you're going to see a document come out from the International Society for Traumatic Stress. It's going to be essentially the first standard of care for complex PTSD. So this is it. You're going to see it here. But it'll be available, it'll be published in November of this year. So this is a consensus model that's evidence-informed, but not evidence-based. We talked about research and resilience this morning a little bit for those of you who were there. We said how hard that is. Try researching this. It's really tough. But what's really, I think, interesting is that the contribution that Chris made was that she looked at each of the stages, safety, remembrance, and mourning, and reconnection, and said, boy, we should have really specific treatment outcome goals for each of those stages. We shouldn't look at outcome over the course of the whole treatment. We should look stage specific and measure our helpfulness by those goals that are appropriate to each stage. So let's walk through early phase objectives, goals, tasks. Number 1, establishing the treatment frame. Boundaries are really important in this kind of work, right? You know this. So establishing all the ground rules of psychotherapy. When are we going to meet? How often? Is there money involved? What's the payment? How do you what are the provisions for after hours emergency contact? All those real basic treatment frame issues. In the old kind of traditional psychodynamic sense, the treatment frame. The structure that serves as the container for doing the rest of the work. Development of the therapeutic alliance is an ongoing thing that starts in the beginning. What makes us different from other kind of psychotherapies is this notion of traumatic transference, which is the idea that people who have been chronically traumatized may approach you like they approach everyone else, which is with the suspicion or the expectation of being hurt or violated again. Unrecognized traumatic transference is the #1 cause of impasse in consultation-based psychotherapy. So when somebody sends a patient for consultation, and you're trying to get a sense of what's going on, and the therapy is stalled, almost always undiscussed negative or traumatic transference is in the mix somewhere. So don't wait. Go for it right away. I explain the concept usually in the first 2 or 3 sessions. And I frame it as, if this happens, and it probably has already, that's the kind of stuff I say, this is good news that we can talk about it. All you have to do is tell me and we'll talk about it. So eventually what that can look like, and we mentioned pseudo-hallucinations, well into the treatment, people will talk about hallucinating a perpetrator's face on you. They'll be looking at you and seeing the perpetrator. And that's a non-psychotic experience. Okay, so this gets intense if it's not managed.